My name is Barbara Eichhorst. I'm consultant at the University Hospital in Cologne in Germany, and I'm secretary from the German CLL Study Group. And I was kindly invited here to the European School of Hematology meeting on lymphoma, and I was invited to talk about CLL treatment and how you should consider genetic testing and what are the future strategies in CLL. So in CLL we treat patients according to different risk factors, including of course the stage of the disease. Since as indolent lymphoma we treat this disease still only in advanced stages, but also age, fitness, and particularly among the genetic markers IgVH status and TP53 status are extremely relevant. TP53, we know that this is one of the most important prognostic marker with a very adverse prognosis for patients. Unfortunately, it seems that even with the novel agents with B-cell receptor inhibitors, as BTK inhibitors, for example, ibrutinib, the prognosis seems to be a little bit inferior in comparison to all other CLL types without that genetic marker. However, the novel agents are the standard of care in CLL with this adverse factor. Mutational status helps to define which patients could still qualify for chemoimmunotherapy, because we see in some patients extremely long-lasting remissions when they have a mutated IgVH status. On the other hand, we see the majority of the patients requiring treatment have an unmutated IgVH status, and they benefit from upfront treatment with BTK inhibitors. And in the US and next year also in Europe, an alternative was approved, which is the BCL2 inhibitor venetoclax in combination with obinutuzumab. Well, the combination was tested as in the CL14 trial of the German CLL Study Group and showed here superiority with respect to the progression-free survival. The advantage of this regimen is that it's a fixed duration for 12 months and it's not continuously ongoing. What I also discussed in my talk, how the landscape will develop with the huge knowledge we also hear here at the conference. For example, that we will be able in the future to test circulating tumor DNA, so we will be able to describe more precisely how deep the response of a patient is on the one hand. On the other hand, for example, circulating tumor DNA or several testings of the CLL cells will also allow to look for clonal evolution or also for resistance mechanisms. Because there are now more and more data coming up showing patients not responding anymore, for example, to BTK inhibitor, but also to venetoclax, that one of the reasons why this is happening are single mutations in the binding pocket for those drugs, and that they are not able to bind anymore tightly, and therefore there is a significant loss of efficacy of those drugs. So these mutations occur sometimes already months before patients have clinical progression, and therefore maybe one future scenario could be that we test routinely for these upcoming mutations and then adapt the treatment. This was from my presentation on CLL. We had other excellent presentations in this symposium for mantle cell lymphoma, diffuse large B-cell lymphoma, follicular lymphoma, and CNS lymphoma. And what all of these presentations showed, including CLL, is that we have a huge increasing knowledge about risk factors. For example, TP53 is also extremely relevant with mantle cell lymphoma, but what we have to learn how we use these risk factors, also deepness of response in follicular lymphoma, in order to adapt the treatment strategies in the future. And this shows also that probably it will be difficult to do extremely large phase 3 trials in the future, because we will probably have more and more smaller segments of lymphoma patients where we address specific questions. For diffuse large B-cell lymphoma, Laurie Sen presented again that we still have the standard R-CHOP for this entity, which is good, a very curative treatment for more than 60% of the patients, but it's still difficult to identify those patients who do not benefit from R-CHOP alone. And all trials also at this year's Lugano meeting, the trials adding lenalidomide to R-CHOP did fail to show an improvement of this regimen. So there's a lot to be done in lymphoma and in lymphoma patients, and particularly in high-risk patients, and those patients who are not in complete response or probably still have circulating tumor DNA. I thank you very much for listening to this program, and we invite you kindly to follow the communication.